Thank you very much. And Julie, thank you for your slides and your program. They were really great. I appreciated them. I'm going to take some of this back to my not-for-profit Medicare Advantage program. So thank you very much. I'm going to spend the first part of these minutes talking about the program on the ground. I think this was discussed that Sharon has indicated just what's actually happening, and I will give a context, and I'll spend the last few minutes just sharing some work that I've been involved with on the last 4.5 years here in San Francisco, helping to develop an advanced geriatric emergency departments, GEDs that have an accreditation. The San Francisco project in particular is focused on people with dementia and doing some screening in the emergency department. So I'll speak to that as well. So next slide, please. What is PACE? We hear the acronym. I just wanted to have you see it in writing, that it is the program of all-inclusive care to the elderly. I spent about 25 years in San Francisco at this program, from the point of first getting some funding from Terry. Thank you for the John A. Hartford Foundation, our early support in doing research, the Robert Wood Johnson Foundation, thanks to Bruce Vladeck in those early days that helped us replicate when he was a vice president at the foundation, and came to see us when we had a site of a burnt out old bar, which is where we started our work. And then also, incidentally, Bruce was the HCFA administrator at the time that we were able to pass the PACE legislation in 1997. So this acronym PACE, I can tell you a little inside joke, and that is we'd say this is pray to avoid catastrophic events. So this is what happens when you're in a full capitated program. Next slide, please. The system it's an integrated system of care that's really focused and anchored in the community. Let's keep going. And it's community-based. It has a full range of medical, non-medical services. We have global payments and this coordination of care that has been discussed about care transitions and all is all built into this program. Next slide, please. And it started off actually in the disability funding and research that was done, which is why you see the age 55. And so normally we think of Medicare programs starting at 65, but this actually does address disability even earlier than 65. And it's very regional based. So when it was discussed, how do we have these programs? Is it through an MA program? Is it through primary care? Basically, there's a set of zip codes that are approved both by the state and the federal level. And the people who are enrolled state by state, even though the slight variations as to what constitutes nursing home care, this actually has to go through that filter to qualify for this program. So this is not your well and healthy. This is where people have complex issues. And the fact that there is the feasibility of living in the community. Next, please. And in terms of all the conditions, I really appreciated Dr. Sherry's comment about, are there programs already that are around that can be tweaked? And I picked up on that in particular because the fact that there are comorbidities, multiple morbidities. And as it turns out, because the average age is in the late 70s, early 80s, about 46% PACE indicates are people who are living with dementia or with Alzheimer's, and they take multiple medications, and they have these classic chronic diseases, because unlike some programs that are focused only on dementia, when you hit the age that our population is, they there is comorbidity along with dementia, along with the functional losses. Next slide, please. It's small in scale. In some ways, people think of this as, is this like an MA program? The short answer is no, because it is more akin to a nursing home population. So nursing homes are not, in the cast of thousands. And so it's really a much more regional, general location that serves up sometimes 200 to 300 people per site. Next slide, please. This is probably the core slide in this whole deck. There are only 8 slides, but people have talked about having a full team, that the care is managed by a group versus an individual case manager. The social worker, incidentally, is the core case manager, but there is medical case management and there's home case management. So all this is actually brought together. It's a continuous, ongoing process of assessing, planning, providing the services, monitoring, and adjusting. So the real-time adjustment that was alluded to earlier does happen here. And so it does both primary prevention, so we can really try to help people manage their cardiac conditions that we know oftentimes have an impact here, as well as dietary, obesity being another risk factor. So there's primary, secondary, and tertiary care, which includes hospice when necessary. So you can see the full range of services from at-home primary care, specialty care if they need an orthopedic surgeon, if they need to go to the hospital, if they need to be in a nursing home facility. All that is included and it's coordinated by the team. Next slide, please. The competency is that this is a provider-based model. So this is an example of something that is a hybrid model. It's not a primary care office. It's not solely an adult day health clinic. It's not a licensed outpatient clinic. It is, it's hospital care. It is in all these settings, but it's provider-based, directed, managed. And it's tightly controlled in terms of understanding our utilization and knowing that you could have somebody go in on Friday afternoon or get discharged Friday afternoon. Medications, food, home care is ready to go when you come home. And the nursing home population, as defined earlier, their data available in terms of satisfaction, high enrollee continuance, I think at most 1% disenrollment. And it has, during the COVID period, the infections and the deaths were much lower than nursing home. Next slide, please. And this is the last slide. It's the fact that the money comes together, which includes both Medicare and Medicaid. And this is included, and not only are the core services given by Medicare and Medicaid covered, all the social services, including podiatry, dentistry, audiology, all of this is packaged in along with the home care. And even if some people live in places where there's no air conditioning, people, the PACE programs have bought air conditioners to make sure that the home is right. So this is a very fluid system, and this is the core program. Right now it's in 30 states in the country. There are 144 providers with close to 300 sites. So it's growing, and the Bipartisan Policy Commission is coming out with a report in July of this year, in about a month and a half, to really talk about how to expand this. So one area that could certainly be looked at a little bit more is the whole area of dementia or Alzheimer's, but already it is packaged into the program rather than the fact that it's only for dementia. So what I'll do is I'll wait to the next round and have a chance to talk about the geriatric emergency departments and just adhere to my 10-minute time zone here.
Okay, Jenny, if you wanted to go ahead for a couple minutes and talk about your geriatric ED, that would be fine.
Sure, I can do that in 2 minutes. There's a whole movement by the American College of Emergency Medicine, emergency physicians, along with the Society of Academic Emergency Medicine and the American Geriatrics Society. Dr. Pete Holman has been the most recent president. And the Emergency Nurses Association. So these 4 entities have been working on policies and processes about this. Bottom line is, fast forward to where we are today, there are about 250, 275 accredited geriatric emergency departments around the country. And the VA system has already probably about 40, and they have committed to having all their hospitals with EDs have GEDs part of it. What we did in San Francisco is that we were fortunate to have funding from a private foundation, the Dolby Family Foundation. Mr. Dolby of the Dolby Sound System had the diagnosis of Alzheimer's, had gone through emergency departments, had some experiences that most of us would understand is less than optimal. And so after his passing, his family has committed to helping look at what could be done in San Francisco. So there are 3 big systems now: UCSF, the Academic Medical Center, Kaiser, San Francisco, as well as our safety net hospital, Zuckerberg. And the whole aspect is helping the advancing the accreditation process, but more particularly because of our particular genesis with the Dolby family. The particular lens of dementia is a part of our development. So the ability to think about some of the tools in emergency departments, given the cadence, how do we begin to do the screening and what kind of validated tools there are. So we're working also with Dr. Eula Wang from Yale, as Chris Carpenter, Manish Shah, and all, to really think about dementia and the ED. So papers are coming out in about 2 months about communication, care transitions, best practices, and making sure that we have that kind of understanding of what we can do from a research base. That's it.
So important, Jenny. I'm so glad to hear that, because as we know, people with ADRD, very high risks of hospitalization and very high risk of complications from those hospitalizations, with delirium being the leading one. So I'm hoping they're screening for delirium risk and putting delirium prevention into place.
If I could just give you one comment about that very thing. The GED, the Geriatric ED Collaborative, has received funding from ARP, thank you, Sarah Locke, that 2 videos are getting produced this fall, one on delirium in the ED and one on dementia, so that this is going to be made available not only to the geriatric EDs, but they will be made available to all EDs, so that it will help the staff be able to recognize and have some formal video knowledge about this.